My story began with a death sentence.
My beginning is before AIDS.
She talked about this new disease. It was going to change the face of medicine in South Africa.
Very few of us had any understanding of the epidemic.
Really, I had absolute, complete faith in the fact that, science would prevail.
When the epidemic first came, I thought it really didn't concern us. It was a problem of white gay males in California, and that was a dreadful mistake because, as you've seen, from the 80s, we've become the worst affected country in the entire world.
We had HIV. We didn't have the drugs at that stage.
The drugs haven't arrived.
Who could afford to be on the antiretrovirals? And you were talking about $10,000 a year.
Yeah.
We had this real view that there was new hope. I think we were all a bit patient. We were saying, Mbeki comes to power and we need to allow him a bit of time to bed down. Same was true for Mantu.
What I kept hearing was, you wanted a policy on treatment, you've got it.
Some of the memories I have is of a lot of people dying, a lot of friends dying, personal confrontations that I had which were unpleasant with the former Minister of Health.
It was already known that the infection in children can be prevented, and yet they were still dragging off feet.
There was a bit of conflation of the issues. We then got into a bit of a debate which polarized us as a country.
As we grew, AIDS denialism hardened. As it hardened, we had to fight it harder. As we fought it harder, Thabo Mbeki, being a proud and arrogant man, hardened his position further, and unfortunately we got into a kind of, I think, vicious spiral.
There were very few people who supported us fighting Thabo Mbeki. And within the government itself, if there is a handful I can think of who stood up, it's a lot.
From an international perspective, we were embarrassed.
Bearing in mind that it's always been the case that an effective response will have to be a national response.
What moved and inspired and motivated you in those days was the personal interactions with people.
I think it's right to capture this history.
Is there a beginning to these issues? I guess for me, I got involved not voluntarily. As just an ophthalmologist in private practice.
An ophthalmologist, okay.
Minding my own business. But I had been involved in medical politics before. I've been in the leadership of an organization called the South African Medical and Dental Practitioners, which is a non-racial organization, but the majority of the members were largely black. That was the time when the medical representation was still divided. So after unification of the medical profession at the insistence of the first Minister of Health, Dr. Nkosazana Zuma, and because of the challenges inside our own organization, I was part of the initial talks of the medical associations coming together, and I put forward the proposal of a 50-50 representation, which happily was carried out. But for many other reasons, I went into the background. I went out of medical politics, went into my practice, and got into corporate medicine with South African druggists. But I was then asked by the SAMDP to be a councillor in the medical association. And one Sunday I had a nice golf game arranged, and I was urged to attend National Council. And I just went by the by to say, when the opportunity presents, I had my golf clubs in my car, I'd leave to go and play my game of golf. I got there and found a divided association, and because of comments that I was made, by the following day I had been elected as the new chair. The whole board had been cleaned out and a new board was put up, and I was elected the new chair. That was in September 2001.
What were I'm curious, what were the comments that you made that you think resulted in your election?
Well, there was a lot of wasteful expenditure. There was a lot of infighting. There were a lot of personality clashes. We were going back to a black-white divide. And I said, I mean, this is irresponsible. We got to get on with the business of the association. We got to put this thing behind us. And the people must forget their differences and do what they were elected to do. You know, to say, you know, this is a mess. And we need to clean this mess up. This is unacceptable. And for my troubles, I was elected as chair of the association. Having been elected as chair of the association, this was 2001. I had been in the periphery of the International AIDS Conference in 2000 because we had a group of doctors that used to come in from the US and we used to do outreach work with African American specialists who'd come here at their own time, at their own expense, and they'd team up with African specialists in the country and would go out and do outreach work. So we came to the conference as a group. Yeah. So, you know, but my involvement with HIV was just as an ophthalmologist, with presentations of HIV patients to ophthalmology and nothing more. And I was in medical politics, but I was not in an HIV arena. But what became painfully clear was, you know, I still have the memory of Kgosi Johnson and his speech at the AIDS conference, and it stayed with me. But I did nothing about it, you know. I was just a silent victim like most of us are. And having become chair, it was at the height of a policy of no treatment. And as the chair, I now had to engage on behalf of the profession. And when I got into the association, I said, but there are no policies or statements that the associations are making on the most pressing health issue in our country, HIV and AIDS. You know, and I said to the association, you need to get engaged. So at the next National Council of 2002, I forced the association to get involved. I forced the association to become a corporate member of TAC. And that coincided with the time that Zaki Ahmad took a stance that he'd rather die than take ARVs. So I then got the association to get involved, become a member of TAG. And as the chair, I undertook to go and see Zaki. I went to Zaki Ahmad and I said to him, you know, you're going to be a martyr, you'll be dead, and everybody will forget, and we'll get on with our lives. Take treatment. And Zaki said, no, I will not.
It's his treatment strike.
So I moved back from Muizenberg, went back home, left a sick Zaki in Cape Town. And I said, what are we going to do? He said, if you can't treat ordinary people, I'm not interested. Within 24 hours, I got a call from the past president, Nelson Mandela. Yes. It so happened that he also went to see Zaki on the same issue. And I guess he got information from Zaki that I'd been to see him. You know, and I think I went to see Zaki before the past president, Nelson Mandela. So I then got a call from Nelson Mandela. He said, come and see me. He was in a retreat somewhere in Limpopo. And I had to drive out to Naboomspruit to go and see Nelson Mandela. Spend an evening with Nelson Mandela, I had dinner with him, and we spoke about the issues and the dilemma that Zaki presented. And I said to the past president, if we want him to stop, we'll have to start a treatment plan. That's the only way he was going to stop. And from there, I was then forced to go to HIV clinicians, and I went to Gary Martins in Cape Town.
How long did that conversation go on? And I mean, what was
I spent more than 4 hours with him.
What was the tone of it? Was there a kind of urgency to it?
Oh, there were lots of things that came up. There was a sense of urgency. He tried to see the president. The president was not available for him. He was referred to the deputy president, Zuma. Yes, he was referred
around.
Yeah, and the president said, I don't deal with HIV. It's a vice president's portfolio. And Zuma was in the Great Lakes, and so Madiba had to wait his time for an appointment with Zuma, and it was distressing him.
I guess.
He had to stand in a queue, and he was extremely agitated about that issue. He wouldn't express it, but you'd see it, and he, the humble but resolute man that he was, he said, "What can we do about this issue?" And but there were also other discussions. I had to inform him about HIV and AIDS, that you can't get it from hugging people or shaking their hands. So we went to an in-depth discussion between a medical doctor and a leading lay person who needed all the information about HIV and AIDS.
Do you wish you could have had that conversation with Mbeki?
Well, we had tried to have a conversation with Mbeki that was not successful. We had asked for an appointment with the president that was not successful on that issue and many other issues, and even he couldn't get in there. So for me, I sat with Madiba and I made a commitment to Tata that I will go and we will start a treatment program. So I left, went to the association and told them we need to start the Tsepang Trust. We need to start a treatment program. Eventually it was named the Tsepang Trust after baby Tsepang. And after a lot of upheavals, we had a fundraising dinner and we got Madiba to come and speak at the Marentia Dam openly on HIV and AIDS, and he became an HIV activist following on Zaki Ahmed's action. We then started the Tsepang Trust as a cooperation between the South African Medical Association and the Nelson Mandela Foundation. The Nelson Mandela Foundation pledged 10 million rands, and the first person to be put on treatment in a public facility was paid for by the Tsepang Trust and the Nelson Mandela Foundation at GF Jooste Hospital. So on the 1st of December 2003, Madiba launched the first treatment program in a public facility.
2003.
We could only do it in the Western Cape. The plan was to have 2 sites in every province, 1 urban, 1 rural, but we could only operate in the Western Cape because in the 8 other provinces where the ANC ruled, it was unlawful to put people on life-saving medication. It was illegal, it was unlawful. And to do that, you were treated like a traitor to the cause.
The cause?
Oh, yes.
The cause being?
The cause being the cause chartered by the ANC government.
Right.
You are defying the government. Now, there was a pledge of 10 million rands from the Nelson Mandela Foundation. We put a treatment plan together that had to conform to the recommendations of the WHO. We didn't want a treatment plan that was based on private regimens. So we based it on the UNAIDS and WHO plan for HIV. So the drug regimens were centered on those, and we negotiated with the drug companies for access pricing, which would be what they would charge the government if they were selling to government. And the treatment plan was started, and we put ARVs in GF Jooste Hospital. There was a great team of HIV clinicians. They ran an HIV clinic, and they just watched people die. So we put drugs in that made a difference. In between July of 2003 and September when we launched, Cabinet made an order to the Department of Health to go and put a plan together that they could present to government. So by April 2004, the government pledged that it would start treatment.
That was
on April 2004.
Mandela's plan that she was working on.
Yes, but that was instructions from Cabinet to say put a treatment plan together.
Yeah. Okay.
So basically, treatment was started. But prior to that, I led a delegation to the Ministry of Health on various issues. We were embattled with certificates of need. Doctors were going to be restricted and told where to work, where they can't work. And we fought that from the association. But we also took the HIV issue to the ministry. And we got there. And it was during the time of the summit on environmental sustainability that was held in Sandton. And the minister came into the meeting and she said to us, I only have 5 minutes for you because I've got to be with the president at this summit. She spent 2 hours. But the 2 hours was spent lambasting me for things that I've said because I had referred to what was happening publicly as genocide. And the minister took offense at that. And we sat there with the then Director General, Ayanda Nzaluba, and the minister and their team. And they clearly said to us, if you can't treat everybody, you treat nobody, which I found objectionable.
Sort of solidarity of death.
You know, and that had been repeated in other meetings before.
If you can't treat everybody,
you treat no one.
You'll treat
That was the explanation for the policy of no treatment. Besides the other issues of toxicity and other alternatives.
How did you feel when you heard those words? If you can't treat everyone, you'll treat no one.
I told them that's genocide. And that we're not going to stand by and watch our people die. And for me, I think there must have been a sense of guilt amongst the ANC leaders in terms of how the epidemic had been managed. If you look back at our figures, we had a rumbling Thailand-type epidemic up to the late 80s. Yes. And getting into the early 90s, it started rising. And the rise in the epidemic coincides with our perestroika. With de Klerk making pronouncements, the unbanning of the political movements, people coming back. And when people came back, unfortunately, they lived in high prevalence countries. So the prevalence amongst our returning fellow South Africans was much higher. But there was no plan to manage HIV and AIDS. Everybody, the previous government had their heads buried in the sand. And during that period of 89 to 94, the virus thrived and multiplied. And when the people took over, they didn't put any coherent plan to stop it. And it might be, part of it was, we should have known better. We came from high prevalence environment. We managed camps. We sat in countries where the prevalence was quite high. So they knew more about the dangers of HIV than we did inside. And that there might have been ambivalence with respect to that. And when they thought of the cost implications of treating, remember, in 94 there was still a lull because, there was no treatment. HIV was a death sentence. Heart only came about in 97. And when Thabo launched the HIV plan as deputy president from Doornfontein, Heart was available at that time. But the cost was horrific. It was $5,000 a month to treat a person. So I think there might have been in their minds the background of not having done anything concrete. Because remember, the Ugandan experience was there.
Yes.
So dealing with HIV required leadership, not just money.
Why didn't we learn anything from Zimbabwe?
But I'm not sure what was there to learn from Zimbabwe. The main learning experience was from Uganda with their zero grazing policy. So I'm not too sure what the lessons from Zimbabwe would have been. Because what happened in Zimbabwe is that treatment was made available. So I'm not too sure if they were strong on behavioral change. What was clear was the cost implications were massive. Because Heart was available. The sleepiness goes back to before Thabo. And by his own admission, Madiba said, I wasn't aware that HIV was a major problem. So one thing that we should be truthful about is to understand that Thabo inherited a full-blown epidemic. But he wasn't president when the fire was alight. The fire was really alight during de Klerk's time and during the first 5 years of a democratic South Africa. And Madiba was president then, and he admits to that. So there's a lot of things that could have happened. Their position just aggravated a terrible situation. And people were dying. And you know what is ironical is that even if they had a policy that was consistent with the policies elsewhere, and we never had chemotherapy for cancer patients, but we never had a policy of no treatment. So it was left to the institutions. So the little that they could do, they would do. If they just had that, it really wouldn't have made a difference to people dying. But it would have made a difference in terms of their outlook. Because left to do what you can within your budget, and it is not illegal to buy ARVs, most institutions would not have bought ARVs. They would have continued to battle with what they were battling with. You know, and that's for me is what puzzles me. Why they felt they had to make that call when they didn't have to make that call. And really nothing would have changed. I mean, TB has been curable, and we've never had a high cure rate. It's gone down with HIV and AIDS, but we muddled along. You know, everybody that needs asthma treatment doesn't get asthma treatment. Everybody that needs epilepsy treatment doesn't get the best drugs for epilepsy treatment. But we don't have a policy that if you can't treat all, don't treat anybody. This was just tailor-made to HIV, not applied to any other illness. And that was frightening. So for me, that's how I got involved in HIV. I'm not an HIV clinician. Even to date, I'm still an ophthalmologist because that's my training. I'm an activist, but I'm not a clinician. So I'll treat ophthalmic complications of HIV when they come into my discipline. But I don't provide ARVs, I don't treat people, I don't do VCT, I don't do counseling. I'm an ophthalmologist. But I ensure that there are resources and assist the people that have the responsibility to treat. So basically, historically, that's where I come from. But you know, so we've seen denialism about cause and treatment. But unfortunately for us, we've perfected denialism. And denialism continues today. You know, we had denialism about cause and treatment. We're now in denial about prevention. Because you see, what I find frustrating is that there's the Ugandan experience. And the Ugandan experience, the backdrop to the Ugandan experience was at a time when heart was not available. You died. If you got HIV, you waited to die. Testing was not accessible. You had to do a blood test that went to the lab for 2 weeks, if your country had a lab. And it was very costly. You did the antibody test, and it was very expensive, and you waited for 2 weeks. Condoms were not readily accessible in Uganda. They didn't have access to them. They didn't have a campaign to distribute them. But what was known was that HIV is a sexually transmittable disease. And the Ugandan miracle was based on 2 issues. If you're sexually active, you are at risk. It's a sexually transmitted disease. And if you reduce the number of partners you have, we can reverse the impact of HIV and AIDS. Fairly simple. They called it zero grazing. It was in their hands. Museveni led by example. They enforced it from the top. And the prevalence of HIV moved from double figures, around 11% in Uganda, to around 5%, from the late 80s to the early 90s. Behavior change. You know, there's no donor funding, there were no jails. There was none of the things that we have right now that are confusing us right now. Extremely effective program.
Confusing us. Things that are confusing us.
Oh yes.
The donor funding and the policies and the...
Oh yes. And
NGO politics.
And the NGO politics and the scientific community and the interventionist approach. You know, if I can't sell you something, I can't help you. Why can't I tell you that you can help yourself by changing your behavior? The most powerful drug against reversing HIV is in the hands of people. Behavior change. We had denialism about treatment. And we went on head on with that. It started by people living with HIV and AIDS. But the serious denialism about prevention. And it's convenient. It's not business as usual. I mean, I'm amazed at the fact that the fight against multiple partners has disappeared from the vocabulary of this conference.
Have you noticed who our president is?
Yes, but now we've joined him in being in denial about what needs to be done. That's why I'm saying we're entering a second phase of denialism, much more dangerous in my opinion than the previous phases of denialism about cause and treatment. We are in denial about prevention. And that's what puts us at risk as a population. That's where, you know, I find, because there's this new found joy of a working relationship between the DOH and activists. Both of us are in cahoots about being in denial about behavior change. But you know, what I find frightening is I'm a medical doctor, and our background is that for us to accept something as standard and as this is a victory, we're talking 98% success rate. We're talking success rate in the high 90s. Then we say the work is done. You know, one of the landmark studies that we were taught about in medical school in the 70s was the study done by Johnson & Johnson about the effectiveness of condoms for prevention of pregnancy.
Right.
And condoms were found to be 80% successful in prevention of pregnancy. But they had a 20% failure rate, which we found unacceptable. And that's why alternatives were sought out, and oral contraceptives and injectable contraceptives were developed, because 20% failure rate was unacceptable. We now, you fast track to 2011, we're selling gels that are 39% successful. We're embarking on medical male circumcision, 50% success rate. Compared with condoms, 80% success rate. Condom costs 2 cents to the government. We're abandoning for medicalization or something that's far less effective than condoms. And we also are not informing the people. We give brief messages. You know, our communication of scientific data is to promote the scientific procedure, is not to promote an enabling environment where people make informed decisions. We now decide for people. So we're in an era of denialism that is far more dangerous than the denialism we come from. We had a president that was in denial about cause and treatment. We now have a president that defies the basics about behavior change. We have a president that has multiple partners. And before this president, we were open about the fact that we need to deal with multiple partners. We need to eradicate the socialization and cultures that promote multiple partners. Now suddenly, that has disappeared from our vocab. Conveniently so.
How can the personal life of a president, how is it possible that the personal life of the president can shut down dialogue about multiple concurrent partners? How is that possible? We're all thinking.
Don't.
We're thinking people.
I think it is not correct to say how is it possible, because we've seen that it's possible. We see it happening. So not only is it possible, but it's happening.
I'm asking you to speculate again.
No, it's not a matter of speculation. It's a matter of convenience. And this is where I find it frightening. You know, when Julius Malema says one president, one wife, the press runs with it. When the Minister of Health puts in his speech of World AIDS Day of last year, stick to one partner and use a condom, nobody runs with it. Now, we can't say leadership has not been provided. At least this minister was brave enough to put it in his speech. None of us have picked it up and run with it. Why? Why? So we can't say leadership on multiple partnership has not been provided, because at least this Minister of Health has provided that leadership. It is there in black and white. He put it in his speech for the World AIDS Day, the 1st of December 2010. Nobody has picked it up. Nobody is running with it. It's science and human behavior. This is not culture. This is misrepresentation of culture. No. No, we make it wear the clothes of culture. It is not culture. Okay, if you take the Muslim community, they practice polygamy on a cultural basis. And they practice it as their culture dictates they should. And they do not have an HIV epidemic. Okay, and that's a cultural practice. So here you have a misrepresentation of culture. And we now want to make it wear the clothes of culture. No.
But it's a powerful conversation stopper though, isn't it?
No. It's a powerful conversation beginner. We choose to not engage with it.
Yeah.
Okay? And those of us that say, let's have this conversation, we don't get the airtime. We have a campaign called Stop HIV, Stick to One Partner. We don't get airtime. But when Malema says, one president, one wife, he gets airtime. So it's the choices that the media makes. It's not that it's not out there. The media makes those. What goes into media is what the media chooses to put in media. The fact that this is a misrepresentation of culture, the media is not putting out there. Because they choose not to. Multiple partners is being crafted out of the dialogues at this AIDS conference. Because the choice is being made to craft it out. We have a cozy relationship with government. We don't want to mess it up. It's not about scaling back. It's not about going to battle with the virus and regaining territory. We're in a cozy relationship. So what do we do in that cozy relationship? We promote interventions. Because in interventions, there's papers, there's funding, there's money. When you promote behavior change, the most powerful tool to stop HIV is in the people's hands. When I say change your behavior, I can't sell you anything. You know, there's no commodity in that. So we've now gravitating to commoditization of the battle against HIV. And I'm not saying the commodities are not important. But when we can say to people, change your behavior, there's no commodity there. And we're not engaging in that debate. We're not having that discussion. And part of it might be, you know, if you have to talk about behavior change, the lead has to come from those communities. We can't come as Western people or Westernized people to save people. We need to give them the information to save themselves. And I guess, you know, then the credit can come to us. It's not a vaccine we've discovered. And that's why you'll even find people that say, oh, you know, the Ugandan miracle, you can't just explain it on zero grazing. Because we're in a world where we don't want to tell people that saving yourselves is in your hands. We still want them to be grateful because they've been saved by medical circumcision, they've been saved by the jail, they've been saved by the ARVs. But the single most effective weapon, which is changing their sexual norms, which is in their hands, we won't talk about that. It's now in the back burner.
There's that famous expression, we were given the Bible and gave our land in exchange for it.
I don't want to trivialize it.
A rip-off relationship between colonies.
You know, I don't want to trivialize it.
No.
By trying to glorify colonialism. I think it would be a mistake. It's an interventionist approach. And people might not realize this.
Yeah.
There are charlatans out there that are not colonials. There are charlatans out there that promise concoctions that will heal you. There are Ralphs out there, but there's Ubejane out there. There are many other things. So I think we shouldn't trivialize it by trying to promote colonialism.
Okay.
The challenge that you have here is an interventionist approach. Okay, and even traditional medicine has woken, it's an intervention, and has woken up to the opportunities that the HIV arena presents. So let us not make this a black-white debate. Let us not make it the West versus Africa. Let us not even get into the trap of colonial claptrap. This is the interventionist approach that, I went to do a talk to a youth congress in a church in Davidton 2 weeks ago. And I saw a poster. On the door, they have a poster from the Department of Health, HIV and AIDS. And I read it and read it and read it. It's a poster that is after the fact. It's get infected and come and talk to us.
Huh.
Literally. It doesn't talk about don't get infected. It's about what we can do if you know your status and if you're positive. There is nothing about if you know your status and you're negative, how do you stay negative? It's conspicuously absent from that poster. And it's about the interventionist approach, a healthy lifestyle. Come and see us, early treatment, know your CD4 count. It's the interventionist approach. If you look at all the immune boosters, etc., it's after you get infected, we can boost your immune system. So the challenge we have is an interventionist approach. And all of us, we sit here. Medicine is after the fact. If you don't get sick, I'm no value to you as a doctor. Because that's how medicine has been. It's an interventionist approach. But we can only overcome this thing to make interventions available to those that are infected. But we're only going to overcome by saying the 40-odd million that are not infected. How do we ensure that not even one of you gets infected? That's how we're going to win the HIV battle. I've always thought about these things. But it's all about when you have people that are dying, you can't even get to talk to people to change their behavior. When there is something that can be made available to them and they would not die.
Well, it's like talking to people in the middle of a war about the root causes of conflict, isn't it?
Yes. So, it is not inconceivable that the Ugandan miracle would have been more difficult to achieve if heart was available at that time.
Yes, I see.
So my point is, when we spoke to people about prevention, they say, why should I? It's too late for me. So I always saw the fact that prevention is key. I always tell people, cure is costly. Prevention is priceless. And I've always had that notion with me. But there comes a time when it's not right to have that conversation. People are dying. How could I tell someone that's dying about prevention when I can't even make life-saving drugs available to them? But now, prevention is a key, and it's got nothing to do with your status. Whether you are positive or negative, know about prevention is key in your life. Because if you're positive, to stay alive longer, you got to prevent yourself from being reinfected. So now we can have that discussion. And everything is about timing. There's a time when it was pointless talking to people about changing their behavior when they were dying. Yes. So the time is now to talk about behavior change. You know, there are other things that Mark spoke about yesterday. Absent fathers. You know, and I mean, 70% of African fathers are absent. There's a direct correlation with multiple partner socialization and misrepresented cultural practices with absent fathers. Because you see, culturally, when people did multiple partners for whatever reasons, when they did polygamy, you know, multiple partners is not promoted by any culture. But multiple marriages are promoted by some cultures. And there's a difference. And there's a big difference. And nobody even wants to talk about that. You have the notion that because we're black, we can't speak up against black leaders. You know, so it's the same notion. So if you go out and speak against black leaders and you're black, you're accused of being a member of the DA or being a sellout and not being patriotic. So I understand where you come from. After 300 odd years of occupation, it's become easy to fight things that are black and white. Yes. But things that are black on black are difficult to engage in. But someone has to engage in those issues.
Yeah. No, I agree.
You know, so I hear you, but I can also sit here and say, you know, these are our leaders from the struggle. We can't stand up against them. We can't, if they're doing something, it must make sense, you know. At the height of dealing with the denialism, I had medical doctors that used to stand up and say, you know, the president has a point, you know. And I asked one of them, tell me, if the president was white, would he still have a point? They went speechless. So there are areas where we have to find our own racial demons, our own tribal demons, and get to a point where we just become plain, simple human beings. And we also have those battles. But those battles are battles that need to be fought. So I can't fight the battle of being a white woman for you, because I'm not one. Yeah. And I'm going to fight the battles of being an indigenous African man, raised in a socialization of multiple partners as a right. To say it is not a right because it violates other people's rights. If it's a right, why can't it be on an equitable basis? If I can have multiple partners, why can't my wife have multiple partners? You know, so we got to deal with those issues. So for me, we're not out of the woods. And the problem that I see is a problem where we're going to be creating a nightmare, a social and a medical nightmare. I mean, because when you have women start using gels that are monotherapy, and most of them might not know their status. If you're HIV positive and you're using those gels, you're going back to the days of monotherapy. Yeah. You're going to develop resistance to those antiretroviral drugs. You know, I mean, it's what is wrong with us. Why can't we measure as equal human beings? Why is 30% effectiveness good enough for African women? Why is 50% effectiveness of male circumcision something that our leaders are selling to African men? 50% is good enough because I'm an African man. Why am I not being told that a condom is 80%, if properly used, is far more effective, is twice as effective as male circumcision? Are we lesser beings? That lesser effectiveness is okay if it's largely for African people. So you see, for me, as an African, I see continuous discrimination. I see that we still expected to have lesser standards and things that are not, would a 40% effective gel be promoted in a white community? Would it be? Now, for me, at this conference, these are the questions I ask myself. So just understand, for me, that we're getting deeper into the woods. But there are different woods where the scientists and government are in agreement. And society is not being told the complete truth so that they can make informed decisions. Do you know what happens to my colleagues, educated, highly professional African men, when I tell them a condom is no guarantee? A condom is as good as it gets, but it's got a 20% failure rate properly used. And if you're drunk and you forget it in your wallet, it's got 0% effectiveness. And do you know, when people are given the information, then they change their behavior. When people think, I don't have to change my behavior because there's an alternative, they will not change their behavior. People don't do things because it's the right thing to do. People do things for their own self-interest. Men are not going to change having multiple partners because it's good to be a man. They're not going to change because they treat women unequally. They'll only change when change is good for them. And when they are not being given the full information of what 80% effective means, what laboratory conditions for condom use means, what 50% effectiveness means, what 30% effectiveness of a gel means, they will not make the right decisions. Why are we treating women as lesser human beings? When we're saying to them, secretly put a gel in. We found a way that you can put it 12 hours before and put it 12 hours afterwards so that the man doesn't know that you put it in.
And so you don't have to negotiate your sexual
You don't have to negotiate.
Yeah.
So people will now be putting a gel, hoping for action, and action might not come your way.
Yeah.
And you've put an antiretroviral in your system, just in case. You know, a key thing in our program of Stick to One Partner is we take Einstein's theory of relativity, E equals to mc squared. And we use it in our teaching. And we've had this for many years, even prior to now. We started this 5 years ago. We put it into our documents. E is for empowerment of women. The small m is for male. I call it rehabilitation. My team calls it reaffirmation. But I think African men need to be rehabilitated before they can be reaffirmed. And the C squared is for squaring our efforts on prevention. Yeah. Where we still talk about A, B, C, D, and E. And we say to people, it's your choice. But understand, abstinence is 100% protective. Nothing works better than abstinence. Sticking to one partner is the next best thing to abstinence. Very, very protective. More than any intervention that anybody is going to give you. We're not saying don't do sex. But if you do sex, let it be intimacy between two people. That's the best form of protection. If you can't do that, we then cascade it down and teach them. You use a condom, properly used, not drunk, etc., etc., 80% effective. And our issue is, there are no substitutes. You know, stick to one partner and use a condom and circumcise. You know, we haven't gotten to where we put and use a gel, because at 40% effective, as a medical scientist, they say that you put in the bin. Medically, we discard anything that's not above 90%. Even at 80%, we do more research. Now, to be promoting for human consumption, 39% effective with all the other pitfalls, just because we don't want to challenge respect for women. I mean, you can't reverse the epidemic if you're not going to deal with the blatant disrespect for women.